Sheng, one of the faculty at Boston Medical Center. Very excited to be here today to talk about something that we as emergency room physicians do every single day, hundreds of times a shift, and that is to make decisions. Before I start, I want you guys to reflect a little bit. Think about someone who you look up to as a master diagnostician. Someone in your own shop, someone from your training, someone on TV like Dr. House. What were they doing that makes them so successful? Dr. House was popping pills, but outside of that, is there a universal process that people are going through that if they're undertaken by anyone, regardless of experience and knowledge, can get to the right answer? If we can bottle that or put it in a can like craft beers here in Vermont and sell it, that'd be awesome. And as a clinician educator, I get comments and feedback on the diagnostic reasoning skills of our trainees. So this medical student has excellent clinical gestalt. That resident needs help developing their clinical acumen. The problem, though, is a bit of a chicken and egg. Is it really a good diagnostic reasoning process that results in accuracy? Or is it a good patient outcome, a lucky guess, or just a well-understood answer that gives the appearance of good diagnostic reasoning? Or maybe just having good knowledge of the issues surrounding the problem gives you both an increased chance of being able to solve it properly and be able to talk about it in a more coherent manner. So as you can see, it's more complex than just having good acumen. So our goal today is to summarize the key principles in diagnostic reasoning as they apply to our decision-making in the ED. And for our purposes and in literature, diagnostic reasoning, diagnostic decision-making, clinical reasoning, all talks about the same thing. The ability to make a diagnosis. Doesn't get into the nitty-gritty of all the other decisions we make on a daily basis. By the end of this talk, you'll be able to illustrate some of the history and theory on the diagnostic reasoning. Appreciate, for those of you who have some knowledge in this, that it's more than just System 1 and System 2. And recognize some of the unique factors that affect us in the ED, and then synthesize a multimodal reflective approach to your next shift. So we'll start with a little bit of a history lesson. In the 1960s, there's a strong desire to instill within medical students the ability to solve clinical problems. That led to a lot of research, which consistently demonstrated the same results. They couldn't find a content-independent process that separated novices from experts. But they kept trying. In the 1970s, two research groups, one out of Michigan, another one out of McMaster, used observational studies to study clinical reasoning. They basically observed experienced clinicians and medical students interacting with standardized patients. One group asked their participants to do a form of think out loud, to talk about their thought processes. And the other group asked their participants to talk about their thought processes after they watched a video of their interactions. And a general model of diagnostic reasoning emerged from these studies, called the hypothetical deductive method, also known as analytical reasoning. It's what we've all learned in medical school over the years. What this says is that experts, when faced with an undifferentiated problem, reduce uncertainty by generating one or more hypotheses. Then they identify additional features to confirm or refute these hypotheses. So key feature identification. So if you're saying, oh, hey, a patient may have X disease, they must have these features. They might have Y disease, they must have these features. And then they kind of compare and contrast, use a form of mental statistics, determine likelihood. This was touted as the generic approach that could be used in the absence of an organized knowledge structure, that could be used by people to solve problems outside their own area of expertise. The problem, though, is that the process was too general. The quality of this analytical method didn't differ at all between experts and novices. They were all doing the same thing. What did differentiate experts was that they generated not more, not quicker, but just better hypotheses right off the bat. And it was the accuracy of these initial hypotheses that was the best predictor of the final outcome, as opposed to any general diagnostic reasoning process. So something else is at play here. Maybe it was just knowledge. After all, experts have more knowledge than novices. You really do have to know your stuff. And it was thought that it was this increased knowledge that made the difference, as opposed to general diagnostic reasoning processes. So in the 1980s, researchers in diagnostic reasoning called this time period the age of memory. During this time, chess was often used as an analogy to diagnostic reasoning. And the single best predictor of expertise in chess was the ability to recall typical mid-game positions. So after a brief, less than 5-second exposure, chess match, I don't know if people play chess here, that you can typically memorize up to the exact positions up to 80% of the pieces on the board. It's estimated that chess masters have memorized over 50,000 typical mid-game positions, representative situations they might find themselves in when they're playing chess. So maybe diagnostic expertise was, to a large degree, a matter of acquiring and maintaining a large set of representative cases in your memory that could be used as analogies to new cases. So what researchers gleaned from this was that maybe there was a relationship between being able to memorize a bunch of stuff and diagnostic expertise. So they tested this theory in medicine, specifically on the ability to recall a patient's numerical lab data. Probably because it was a good, easy gold standard. You'll see there's a lot of limitations of research in this field. But fortunately for dumb people like me, this failed to translate. This was not important at all. We sometimes memorize a patient's white count or a lactate in short-term memory, but never in long-term. Although there was one specialty in which they did find a consistently positive relationship between the ability to recall patients' numerical lab data and diagnostic expertise. And guess what field that was in? No? Close. I can see what you're getting at. Not surgery, but a lot of numbers. Internal medicine, a lot of numbers too, but a subspecialty of internal medicine. Nephrology, there it is. Nephrology. But since general data recall was not informative, perhaps expertise was related to other types of knowledge and the way they're organized. So in the 1990s, they called this the age of mental representations. And during this time, researchers described 3 distinct kinds of knowledge associated with expertise. Pathophysiology, you guys know that. Illness scripts we'll dig into, and exemplars. And they posited that with increasing experience, clinicians kind of transition through the 3 types of mental representations. From initially thinking about diseases in terms of basic mechanisms of disease, to illness scripts, to examples from experience. And this makes sense because if you're talking to a first or second year medical student or PhD student about sepsis, patient with sepsis, and they're going on and on about endotoxins, cytokines, and just like, tell me what you want to do. Tell me what you want me to do. This patient's sick. Clinicians often think more in a practical, clinical-oriented manner. So illness scripts are a story-like narration of a typical case or problem. You learn it through training, education, clinical exposure. We find through experience this vast library of unique clusters of information for each diagnosis operates at a subconscious level to help us in our decision making. So my illness script for community-acquired pneumonia. It's a lower respiratory tract infection. It has often bacterial, acute, progressive, fever, cough, shortness of breath. You might find crackles. You diagnose it with lung findings, X-ray, maybe a CT, and you treat it with antibiotics. So that's all I have, sorry. So exemplars are another fancy word for examples. You think about a dog or a cat, you can think of many examples in your memory. And when faced with an illness presentation, you rapidly look to retrieve prior similar examples, all without conscious awareness. So schemes are another term that's used during this time. Schemes are an organized knowledge structure for decision making. These inductive trees or roadmaps have these divisions and chunks in them that's used by experts both for the storage of knowledge and as retrieval for problem solving. As you can see, this goes further down than this. I just didn't want to put the whole thing up on a slide. But the further down you get, the number of diagnostic options get considerably reduced. And you can use your pattern recognition or your hypothetical deductive method to get to the right diagnosis. Keep in mind, schemes, just like those illness scripts, are dependent on a patient's clinical presentation. You can't use a scheme for dysphagia for a patient presenting with shortness of breath, nor can you use your pneumonia illness script for a patient presenting with appendicitis. That's because, just like most other skills of knowledge, diagnostic reasoning skills are generally context-specific. Being able to diagnose and treat one disease process does not mean you can do the same for another. The idea of these master diagnosticians are capable of taking care of anybody is simply false. Your resident or your PA who showed great clinical gestalt in diagnosing the patient with PE probably won't exhibit the same skills when they're faced with a presentation they're unfamiliar with. Semantic qualifiers are standard ways of differentiating and categorizing signs and symptoms. So terms like acute, your ears perk up, I gotta figure this out, and you hear the word chronic, you're like, you kind of lose your attention span. Other words, monoarticular, polyarticular, makes you think about different arthropathies, or atypical chest pain, you're like, okay, but classic crushing chest pain certainly worries you. All terms we used to compare and contrast. And successful diagnosticians tend to think using semantic qualifiers more frequently in a more diversified manner than those who are less successful. In observational studies, the increased use of semantic qualifiers has been associated with improved problem solving. But when subjected to experimental manipulation, despite an increased use of semantic qualifiers in the experimental group, we didn't really do any better than the control group. And we'll see this theme as we go on. There's a lot of research in this field. So now remember those patient assessments you always have to say in medical school. So you're presenting a patient, you give your history, you give your physical, and then you have to summarize the case using its predisposing conditions and key features. So here's an example. You have this whole long case, and you summarize it in a very short phrase. These are called problem representations. Apparently they're a lot more important than I thought they were. Here's some additional examples. 20-year-old female, new sudden onset severe headaches. That makes you consider certain differential diagnoses. 56-year-old male, alcohol use disorder, recurrent atraumatic monoarticular pain and great tone. And then the third one. As you can see, the use of multiple semantic qualifiers in these problem representations might enable a clinician to rapidly retrieve illness scripts, consider exemplars, and maybe efficiently narrow down those human decision trees we talked about. So it's important for us to continue to articulate our problem representations accurately. Pattern recognition, you guys all know. Cases compared to prior patterns of cases, and the diagnosis is made when the pattern hits. So a patient presenting with COPD, smoker, wheezing, cough, shortness of breath, sounds like COPD, wheezes like COPD, it's probably COPD. And this is the flesh and blood decision making we use every day. And it works. So I'm sure many of you read the book Blink by Malcolm Gladwell. It talks about the adaptive and conscious mental processes that work quickly and efficiently to get to the root of the problem. Research has shown that pattern recognition from experience to be a very successful approach used by experts to solve clinical problems. This became known as the intuitive or non-analytical approach, as its importance became increasingly recognized over time. So we're just going to compare real quick. So you have your intuitive. On the left, it's more experiential based on mental shortcuts, gestalt, pattern recognition, works subconsciously. While your analytical is based on the hypothetical deductive model we talked about. It's much more rational, robust, and deliberate and purposeful. It takes a lot of work though. And the dichotomy of the two approaches culminated in the development of the dual process theory, also known as System 1 and System 2 reasoning. A lot of you have seen this as well. System 1 is your intuitive approach. It's passive, it's very efficient, you can do a lot with it. It's based on prior exemplars, illness scripts. It's considered more error prone and more prone to biases. Employee ambient conditions requires very little effort. On the opposite end, your analytical part, your System 2, is more active, conscious, deliberate. It's very resource and time intensive. And is considered to be optimally used in ideal conditions. It's quiet, it's nice, you can really sit down and think through your problem. So let's see how this works. In this presentation, you recognize it. It actually looks like shingles. It's probably shingles. So keep in mind that System 1 is more considered more prone to errors and biases. So maybe you diagnose a patient with shingles, they actually have contact dermatitis or poison ivy, or God forbid something worse, and you were subjected to recall bias because you just saw shingles in your last shift. You can see how that can happen. When you don't recognize an illness presentation, you're like, hey, this is complex, this is new. Let me think about this more logically, systematically, identify key features, and maybe seek additional resources. So all that happens. We got what, 20 minutes left? Let's keep going. In the early 2000s, researchers studied the Think Out Loud protocols of experts and residents in the diagnosis of certain GI disorders. So they asked GI attendings and trainees to do some multiple choice questions, do some matching, and then they interviewed them and asked them what their thought process was for each question they answered. And it turns out when scheme inductive, remember those decision trees we talked about, when that method was used, it was 5 times more likely to be accurate than when hypothetical deductive method was used. And then when pattern recognition was used, it was 10 times more likely to be accurate. But obviously this depends on the experience level of the participant, and if they obviously know the answer right off the bat with pattern recognition, we probably are higher chance of getting it right to start with. Another study asked or taught medical students in the diagnosis of certain dermatological disorders. They randomized one group of students to use pattern recognition, and another to identify key features and arrive at a diagnosis more systematically, aka use system 2. And they found no difference in the diagnostic accuracy of the two groups. A later study added a third group that started with pattern recognition, then checked it with a more systematic strategy, and they actually enjoyed a 10% increase in their diagnostic accuracy. And a series of studies taught undergraduate psychology students in being able to read EKGs. And they found that the group that was asked to use pattern recognition and key feature identification, System 1 and System 2, were more successful than the groups that were asked to use either strategy alone. So we should be using a combined approach. That's kind of what the evidence is for. After all, remember that experts have warned against the use of System 1 alone, especially by novices, because it's more error prone, and they just don't have enough experience, knowledge. In order to overcome this, active reflection exercises and cognitive forcing strategies kind of force yourself to think more systematically and logically have been shown to improve diagnostic accuracy and confidence. So let's look at our unmodified process here. Modified. As you can see, in the modified process, a lot more happens between illness presentation and diagnosis than just System 1 and System 2. There seems to be constant interactions between the two. And the most important one of which is the ability of System 2 to override your System 1, to monitor and override. So in other words, System 2 can reject System 1 by applying what's called a rational override. So, for example, your shingles rash crosses the midline. Maybe it's not shingles. If you pick this up, you've got to think about this a little more systematically, more logically, and maybe do some key feature identification. Obviously, being able to keep up with this level of surveillance, sort of self-awareness, takes a lot of work, takes a lot of reflection, metacognition, and any degree of burnout, distractions, inattentiveness, fatigue can all decrease from this surveillance. We know that sleep deprivation and fatigue can increase diagnostic error rate by up to 5-fold. Interestingly, System 1 can also override System 2. It's not a great example, but maybe deciding against the use of clinical decision rules. Patient comes in, minor head injury, they look great, they clear the Canadian SCT rule, but you're like, I'm going to go CT anyway. Occasionally there's virtualness, situational appreciation for things that science, logic, or evidence-based medicine simply just can't account for. But most of the time it's based on historical, emotional, habitual tendencies, or just overconfidence, like I know best. And how do you develop your System 1? Well, you read a lot, you get a lot of experience over the years, and you use your System 2 as a medical student, as a PA student, during your training, and as an attending, really for the rest of your life, so it becomes second nature. So this is a universal model of diagnostic reasoning by Croscarry, one of the experts in this field, kind of fully expanded. And the idea of a discrete separation between System 1 and System 2 is likely an oversimplification. What's really happening is a cognitive continuum with oscillations between the two. And regardless of whether illness presentation is recognized or not, System 1 and System 2 interact in a way that the final output is the synthesis of the two. And this combined approach of dual processing likely offers us the best chance of diagnostic success. So you guys saw this picture already. I think Patrick put this up earlier, and we did not find the exact same stock photo. In fact, we probably saw the same patient. My bounce back, I didn't give him steroids, sorry. But what's your system 1 say? Yeah, so let's apply a little bit of surveillance and override, right? Patrick talked about ruling out a BVT, make sure it's not a neck fash or something more serious. Make sure they have a pulse on their foot. So good. This is another common example we see at DMC a lot. So a young adult male patient with sickle cell disease presenting with back pain, bilateral hip pain, leg pain. What's your system 1 say? Yeah, sickle cell vaso-occlusive pain crisis. That's good. So the patient says, you know what? This doesn't really feel like my sickle cell pain. My left hip hurts way more than the other areas. So at this point, you can choose to forcibly fit the patient into your sickle cell pain box, which we often do from time to time. You haven't peed all your shift, you haven't eaten, it's about shift change time, you want to give a clean side out. You're like, just give them pain meds. It's a great plan. But if you developed this metacognitive surveillance system, which is system 2, you realize that system 1 is insufficient. You need to think about this a little more logically, systematically. So what else could this be? Left hip hurts way more than the other. Avascular necrosis, yes, right, very common, or osteo. Maybe they just ate a turtle. It's classic for sickle cell patients. All right, so that's you guys did very well. So let's talk about decision making in AD. So we're faced constantly by volume, acuity, variety. We make decisions in a data-poor, decision-dense, rapidly evolving environment where further clinical information and tincture time is often unavailable. Although with boarding these days, everybody gets a little tincture of time and the increased mortality is fantastic. But experts in diagnostic reasoning call diagnostic uncertainty the hallmark of immersive medicine. So it's no surprise that much of the research looking at diagnostic error happens in ED, where our error rate has been estimated to be anywhere from 0.6 to 20%. All various studies, poor gold standards, whether it's ICD-9 codes or hospital discharge diagnoses, it's not ideal. But let's dig into this a little bit. So one of the characteristics working in ED is that we're faced every day by interruptions. Here's an EKG, monitor alarms going off, nurse needs something, patient is getting sicker, patient wants a turkey sandwich. It may even be the same patient. But interactions happen every 2 to 10 minutes at a rate of 10 to 20 an hour, and almost 50% of our tasks are interrupted before completion. So it could make us more error prone. Again, experts recommend the use of these cognitive forcing strategies to increase self-awareness. But a recent study specifically looked at the effect of interruptions on emergency physicians. So they watched emergency medicine attendings and residents solve 20 general medical problem cases. And they randomized one group into a time pressure group and another into to work at their own pace. And they added visual and auditory, not hallucinations, visual and auditory interruptions to both. Different study, that would be cool too. But they added visual and auditory interruptions to both groups. And they found that time pressure interruptions had a small effect on kind of increasing the response time of all the clinicians. But diagnostic accuracy was not affected by either time pressure or interruptions. It was related to experience level. Attendings were simply faster and more accurate in essence. So no offense to the residents out there. But we generally dealt with interruptions okay. And as a clinician educator, I get feedback also in terms of how our residents are doing on their off-service rotations. Medicine, ICUs, pediatrics, all generally similar stuff. This resident's very smart, efficient, gets things done, team player, but there's always some constructive feedback that are also consistent. They need to slow down. They need to delve more deeply into cases. We're asking them to use this too, and we should do that from time to time. It works probably very well in their setting, but in our environment, full of interruptions, chaotic, these are not ideal conditions to use your system to, remember. And the high metabolic demand of using System 2 is likely amplified in our environment with so many moving pieces happening at the same time. And based on cognitive load theory, which says you only have so much working memory space to begin with. It is possible that these warnings to slow down, think more deeply, get used to, we should do from time to time to monitor, to override. But if universally applied at every single case, it could actually overwhelm working memory and actually be detrimental. So how do immersive physicians think? In a very interesting study using head-mounted videos, first-person views with their immersive physicians, they asked the participants to talk about the thought processes as they watched the video themselves going through their patient interaction. And we found that, on average, immersive physicians generated 5 hypotheses on their differential diagnosis. They were generated before meeting the patient, or just within the first few minutes of meeting the patient, all subconsciously. The differential was ranked based on key identifying information, so key feature identification. And no hypotheses was completely refuted or confirmed until results of the diagnostic testing was available. So we actually generally kept a broad differential, used some system 1, system 2, and tried to avoid early closure. And this is a picture of a residency. Another study of qualitative study looking at the diagnostic reasoning processes of our junior doctors, residents. The participants reported using constant analytical self-reassurance strategies before discharging the patients. So like, oh, this patient's leaving with their chest pain. I really don't think it's an instance. I think we checked this already. I think we're good. And the researchers found that there was a constant dialect between participants' intuitive and analytical cognition throughout their thought processes. So even our junior doctors are using our own checks and balance systems, cognitive enforcement strategies while employing system 1 and system 2 strategies. That's really good. Although I can't really tell sometimes just by watching. So let's summarize the research so far. In its infancy, diagnostic reasoning was thought of solely as this hypothetical analytical method. And whether this method or any other, it became clear early on that no single diagnostic reasoning process separated novices from experts. Over the years, finally, there's increasing recognition for the intuitive approach based on pattern recognition experience. And that despite the fact that some observational studies make particular diagnostic reasoning strategies seem superior to others, when subjected to experimental manipulation, the differences are really small or not significant. So thinking back on those expert master diagnosticians we come up to, look up to and respect, it's tempting to think that they have some kind of special trick up their sleeve to make them really successful. But there is no single diagnostic reasoning strategy that could be effectively taught, learned, or applied in all situations. Experts simply possess greater knowledge, and all of it may be brought to bear on a solution to a particular problem. And experts and novices generally use a combination of approaches based on the problem, the stage they're at in solving it, what's expected of them, and the prior knowledge and their experience. And remember that current understanding of diagnostic reasoning, which may certainly change over the coming years, can be summarized by the dual process theory, where your system 1 is rapid, efficient, use it as much as you can. It's crucial to the functioning of our healthcare system. The ED wouldn't run without. System 2 is much more deliberate, analytical, considered less error prone, but much more resource and time intensive. Use it when you encounter new cases, complex cases, when something doesn't fit, to monitor and override your system 2. And for your next shift, remember that system 1 and system 2 interact so that your final output is the synthesis of the 2. And the key is to develop and maintain this checks and balance system to override system 1 as needed to avoid errors and biases. And despite the fact that, despite the unique and challenging environment of our ED, we're already using these strategies pretty effectively while providing high quality immersive care to our patients. So thanks and keep up the good work.